Jarbas Barbosa, Assistant Director of the Pan American Health Organization. It gives me great pleasure to welcome you all to this third session of the PAHO webinar series on tackling NCDs, risk factors, and mental health during the time of COVID-19. While we are all discouraged with the long-standing and widespread nature of this pandemic, we can be hopeful with the decreasing trends observed in many sub-regions in the Americas in new cases and deaths of COVID-19. But for people living with NCDs, we are aware that they are at a higher risk of severe COVID-19, hospitalization, and death, and as a result, need to be considered as a high priority population for health services and self-care support. So as we continue to respond to this health emergency, it is of critical importance that essential health services are maintained, particularly for NCDs, which continue to be the leading cause of death in the Americas. With limited resources already stretched to manage the COVID-19 pandemic, NCDs must also be a priority to ensure those living with NCDs receive the care needed to prevent premature death. This webinar will allow universal health access and coverage can improve outcomes for people with NCDs, particularly improving responsiveness from the primary care level needed to strengthen NCD management. We will present how some countries have been improving primary care for NCD prevention, as well as available frameworks and tools for such purpose. I want to recognize and thank the Ministers of Health and health authorities throughout the region who are working under extremely pressure to provide the necessary conditions and services to support the health of their people. And I especially want to thank Dr. Julio Borba, Minister of Health and Social Welfare from Paraguay, and the Honorable Christopher Tufton, Minister of Health and Wellness of Jamaica, for taking time today to speak with us about the work in their countries to continue the NCD services. I also want to acknowledge and thank our collaborator in the Inter-American Development Bank, Dr. Ferdinando Regalia, for joining us in this session today. As a member of PAHO's Inter-American Task Force on NCD, a partnership of international agencies promoting multi-sector collaboration on non-communicable diseases, we will learn about IDB's work on health system strengthening. Now, to lead us in this discussion, I invite Dr. Anselm Hennis, Department Director for Non-Communicable Disease and Mental Health, who will provide an overview of PAHO's work on transforming health system for optimal NCD management. Thank you for connecting to this webinar, and I wish you all a very productive discussion. Over to you, Anselm.
Thank you so much, Dr. Barbosa, and good morning to you. Good morning, Excellencies, distinguished participants, ladies and gentlemen, colleagues. It's indeed a pleasure to be here to share with you some of the lessons learned regarding NCDs in the time of COVID and some of the ideas in terms of health system strengthening for NCDs as an essential program. So I can begin my presentation. Thank you. If you could put it on to presentation mode at the very bottom. Wonderful. That's it. Thank you. Okay. So the title this morning is Including NCD Interventions on the Road Towards Universal Health Coverage and Access. Let's go on to the next slide. Next slide, please. One back. Thank you so much. Okay, so basically, the Americas is the region most affected by the COVID pandemic, and we remain at the epicenter of the COVID pandemic. So effective the 6th of June, there were 68 million cases of COVID, which is 40% of the global cases, and 1.798 million deaths, which is 48% of global deaths, and they take place right here in the region of the Americas. Next slide. Before COVID, we were well aware that non-communicable diseases are the leading cause of death in the Americas, accounting for 81% of overall deaths. And of particular concern is that 34% of NCD deaths take place prematurely in persons aged 30 to 70 years. The majority of these are due to cardiovascular diseases, that's about 35%, followed by 24% due to cancer. So it's really a tremendous burden, as Dr. Barbosa shared with you. Let's go on to the next slide. Now, given the concerns that we have, another huge concern is that the region of the Americas is not on target to meet the global goal to reduce NCD premature mortality by 25% by 2025. This is a major concern for us in the region of the Americas. Let's go on to the next slide. Now, we know that COVID-19 presents greater challenges for persons living with NCDs. And we know that in the region of the Americas, about a third of persons here live with a chronic condition. We have learned a lot about COVID and the non-communicable diseases, that persons with non-communicable diseases are at high risk of developing COVID and having severe cases or increased risk of mortality. There is higher risk of hospitalizations, and we also know, in addition to non-communicable diseases and chronic conditions, that a pandemic has triggered a major mental health crisis in the region and globally. Next slide. Now, this is from a rapid survey, and this study shows the proportion of countries in the Americas reporting disruptions to NCD services. And this took place because many persons were deployed to the COVID response. So therefore, about 50% of countries reported that there were total or partial disruptions in cancer screening, hypertension management, or urgent dental care, whereas about 45% of care for diabetes was disrupted, and as much as 40% of asthma services and 35% or so of cancer services. Next slide. So, however, the COVID-19 pandemic, in addition to being a challenge, also offers an opportunity to strengthen health systems, including those for NCDs. Now, looking at the various pillars, in terms of governance, we have learned that we really must include non-communicable diseases in national health plans and in COVID response plans. Many countries did not achieve this. We also know that there must be policies for chronic care and for risk factors. And that is to help to strengthen the resiliency of the healthcare system. We know also that in terms of health financing, NCDs must be covered in universal health coverage benefit packages. Regarding medicines and technology, we must strengthen our access to and uptake of NCD essential medicines and technologies. And one possible mechanism, one particularly useful mechanism for this region is to use the PAHO Strategic Fund. We know also that there's need to build the health workforce to strengthen the capacity for delivery of primary health care and NCD management at that level of the health sector. Also, there must be a strong integration of NCD services in primary health care and great uptake of guidelines and protocols, as well as referral networks and community engagement. There's also a tremendous need for strengthening health information health systems. Let's go on to the next slide. Now, in terms of a systemic approach to improve NCDs as a priority program, and we look in terms of expanding access to services, strengthening stewardship and governance, improving financing and strengthening intersectoral coordination. And the objective really is to have a people and community-centered model of care. This looks at including health coverage, which includes health service delivery organization, intersectoral action, also access to health, which means reducing barriers that prevent people accessing the needed care, as well as equitable and effective use of health services for NCD management, and access to intersectoral interventions to reduce NCD risk factors and manage NCDs. The health system really must have access to critical resources, as I said before, human resources for health, medicines, and other technologies. And only in so doing can we actually achieve the desired model of care. Next slide. There are many challenges to the integration of NCDs. Care is now quite often disease-centered. So someone who has multimorbidities with, for example, diabetes, hypertension, asthma, will have to see different doctors in different clinics to get care for each particular disease, which leads to fragmentation of care as well as duplication of services. And it's a chronic barrier to the access for quality comprehensive services. We need to transition to a model of care that responds to needs for NCD chronic care. A key bulwark of this system must be improved responsiveness of the first level of care for non-communicable diseases. That's the primary healthcare level. There must be comprehensive health services. There must be a referral system that works between the different levels of care from primary, secondary, tertiary, as is needed by the persons with NCDs. One must also focus on structural barriers. There are a number of groups who live in conditions of vulnerability, for example, migrants, the poor, indigenous populations, and they often are locked out to having full access to quality care. And we really must find a way forward to remove these structural barriers. Additionally, knowledge is power. People must be empowered with information on decisions regarding their own health and their health care. There must be a health and all policies approach which people can benefit from. Next slide. There are a number of challenges to the integration of NCDs, and we must look for solutions. Health plans and policies at the national level must include the NCD programmatic perspective. There must be a prioritization of NCD services, and there's a need for countries to clearly define progressively expanded health services that reflect health priorities. And I think that's a really critical point. There must also be strengthened leadership capacity of the Ministries of Health for NCDs and the creation of alliances to develop normative, legal, and regulatory frameworks. And this is important for NCDs because quite often the drivers of NCDs, which include things like poor nutrition, junk food, sugar-sweetened beverages, etc., tobacco, harmful use of alcohol, as well as sedentarism, these are all issues that are beyond the health sector, and one has to create an enabling environment to make these possible, hence the need for normative, legal, and regulatory frameworks. There must also be an institutionalization of interprogrammatic coordination for NCDs and other priority programs. As Dr. Barboso said, these have to be preserved during the time of the pandemic and afterwards if we're to realize the level of healthcare that we need for populations. Next slide. So therefore, it's important that, that we consider challenges for the integration of NCDs. And a key challenge is low investment, low public expenditure in health. Quite often also the financing is vertical, and it increases segmentation of how health systems work and are structured. Also, we know that there are high out-of-pocket expenses for NCD services. And this is particularly problematic for cancer care. So therefore, some of the solutions, there must be an increased fiscal space for health and a comprehensive health system approach instead of a program-by-program approach in a piecemeal fashion. Comprehensive health services must be costed, and most importantly, they must be financed. There must be integration of resources and budgets associated with NCD programs into health system resources, and we find quite often this is not being the case. There must be strategic purchasing, payment mechanisms, which align with national health objectives for NCDs. And also, as I said before, one must prioritize the first level of care for NCD management. This must be a key pillar of care delivery going forward. Next slide. There must also be, in terms of trying to take care of the challenges of integration of NCDs, strengthen leadership in defining NCD-related components of intersectoral policies. Quite often we find that there's policy incoherence. So what I'm meaning by that, you may find, for example, in a country where they grow tobacco, and that's linked to high use of tobacco. So from the finance and trade sectors of the government, there's an impetus to grow more and have people consume more because it brings money in. But that is totally at odds with health. So there needs to be policy coherence in terms of intersectoral approaches to health. One must also address social determinants of health, and this must include intersectoral interventions in NCD plans, so that those, the causes of the causes are also addressed. We've seen this problem significantly during the COVID pandemic, when those persons who work in the informal sector, those who have the greatest needs, were often implicated as being those who were part of the focus of early pandemic spread in several countries in Latin America, really because there were those who were most at risk in terms of being able to survive with the lockdown restrictions that took place to reduce pandemic spread. So the interventions have to consider the causes of the causes, particularly the social determinants. There must be interventions on risk factors and lifestyles that go well beyond the health system. As I said before, many of the drivers of NCDs exist beyond the health system, so there must be strengthened legislation, taxation, and social communication. Finally, there must be mechanisms for involving people with NCDs who must be at the table and must have a voice in developing NCD policies and programs. Next slide. So there are many tools that WHO has been developing to strengthen health services for NCDs. And as you can see, the PEN package, the HEARTS technical package for hypertension care, the diabetes management module, maintaining services for NCDs, digital health, etc. But what I will say, even though these are packages, this is not meant to be part of the problem. So in other words, these are guidance documents in terms of how to manage individual disease conditions or situations, but it's meant to be applied in a comprehensive, coordinated way for the patient at the center. Next slide. So basically, COVID-19, while a challenge, presents an opportunity to strengthen health systems and prioritize NCD services towards universal health. Strategic investments will be a requirement for a transformed health system to respond to people's needs for non-communicable diseases. There must be an integration of NCDs in strengthened primary health care, which includes building capacity for service delivery. And this is going to be a critical challenge going forward. We must also learn on the lessons that were taught to us by way of the pandemic. We were unable to deliver care in the usual way, and therefore innovations like digital health became far more relevant. We have to keep the new innovations that worked. So working in a virtual environment, digital health, and a great use of electronic medical records and information systems for health must be part of what we take forward in the new world post-pandemic. We must also strengthen surveillance for NCDs with resilient and comprehensive information systems, which include data in NCDs and related COVID outcomes, because there's still very much to learn. Thank you very much for your attention.
Thank you very much, Dr. Hennis, for that very comprehensive summary on the impact of COVID-19 and NCDs and how to rebuild health systems and services during the pandemic. I'm Silvana Luciani from the Department of Non-Communicable Diseases and Mental Health, and I would like to give a warm welcome to those who are just connecting now to our webinar. This is the third session of PAHO's webinar series on NCDs during COVID-19, and Dr. Anselm Hennis, the Department Director for NCDs and Mental Health, just gave us a very good overview of how to rebuild those health systems and services and ensure optimal care for people living with NCDs at this difficult time. And this sets a nice stage and context for our discussion, which we are going to move now to hear from countries in our region. We know that throughout Latin America and the Caribbean, ministries of health are leading the charge to address the COVID-19 pandemic while continuing to maintain those essential health services and make sure people living with NCDs receive the care that they need to manage their chronic conditions. So in this next session of the webinar, we're going to hear from two countries in the region, Paraguay and Jamaica. And I'd like to remind everybody that this webinar is being transmitted in simultaneous translation for English and Spanish. And you can find the simultaneous translation on your Zoom link at the bottom with the little globe that says interpreters. And you can click on your language of choice, English or Spanish. So let's turn now to hear about experiences from the region, from the country perspectives on how health system services are being strengthened to ensure continuity of care for people with NCDs amidst the COVID-19 pandemic. Having our Minister of Health and Social Welfare of Paraguay, Dr. Julio Borba. Dr. Borba is a surgeon with extensive clinical, academic, and health management and hospital administration experience who's been leading the country's efforts to tackle COVID-19 and strengthen health services. And before he assumed the role of Minister of Health, Dr. Borba served as Vice Minister of Comprehensive Healthcare and Social Welfare, as well as General Director for the Development of Health Services and Networks in Paraguay. And before this, he was coordinating specialized hospitals in his country. He's worked as a surgeon in emergency health services and was the head of guard of the Hospital of the Social Security Institute, so brings a wealth of experience to his charge as Minister of Health. And he's joined here today by two members of his senior team, Dr. Guillermo Ceguera, Director General of Health Services, and Surveillance, and Dr. Mirta Rodriguez, who's the Director of Mental Health. So it's an honor and pleasure for me to introduce to you today, Dr. Borba. Over to you for your presentation.
Bueno, muy buenos días.
Good morning, and before I'm going to introduce myself, I'm Dr. Mira Sosa. I'm Vice Minister of Health, of Leadership and Surveillance of the Health Ministry in Paraguay. I bring you special greetings from the Health Minister of Paraguay, who was called out urgently to a meeting with the President and sends greetings and apologizes. Unfortunately, as I said, he was not able to be with us here today and asked me to greet you on his behalf and to say that from the Health Ministry in Paraguay, we are happy to have spaces like these where we can exchange knowledge and experiences with others. I would like to introduce Guillermo Ceguera, Director General of Health Surveillance, who will be making the presentation of our situation in Paraguay at this time. Thank you very much. Thank you, Vice Minister. And I'm going to tell the experience of Paraguay. I'm sorry, I'm losing him. Oh, there he is. First slide. I'm going to share an experience we've had here with what we call the model of chronic care, which is a new way to organize our care systems, and how we strengthen the health system with the management and prevention of NCDs and mental health during the COVID pandemic. This was an experience which is constant learning. I'm going to try to summarize what we've done. The chronic model of care is what we call a care strategy where the medical care is geared in cooperation with the community. It's a health system where the health staff is active, proactive, constantly seeking amongst the community the responses. This is an active community, a proactive community, as we call them. And it's an exercise based largely on the primary health care. And the model of chronic care is focused mainly on chronic diseases and risk factors. All this strategy has a plan which was started around 2014, which frames the way in which we work until 2024. We began, next slide, please. Next slide. We began in 2015 this chronic care model in 3 of the 18 regions of the country, which were used as pilot regions in 3 hospitals. Each one has a main hospital, and they were the highly specialized centers in the region with 128 health family units. In these territories, we worked in a comprehensive manner and worked actively with the community and the service integration principles, stability systems, prevention, quality, always working from the level of the community. We when we did the evaluation of the impact evaluation of the strategy, we felt that it had good acceptance, and not only was well accepted by the community, it was also well accepted by the health system. They feel part of the system, they're trained, and we see tremendous impact in the rural areas and in the peri-urban areas where we've seen the main impact of the indicators of the groups of patients with diabetes, for example, or all the care for quitting smoking, all of these things with the hospital, the micro networks, and the communities who worked actively and obtained some interesting results in these three regions. We began, as I said, in 2015, and in the next 2 years, we assessed them until we reached 2019.
No, I guess that we went too far. You can go back. So I was saying that takes us to 2019. 2019, where we wanted to expand the program across the entire country for the 18 regions in the country. So resolution in hand, we set to work, and we were all taken by surprise with the pandemic. This pandemic had to do with infectious diseases, obviously, but we were seeing its worst case because we had these disease carriers. So that was a shock that we all experienced early on, and there we had to readjust our chronic care model to the situation of the pandemic. Also, we needed to issue guidance on how to manage the different pathologies, how we could work with the community. There too, we had to adjust to the pandemic. And different documents, different resolutions, so as to restructure the health service and to use telemedicine to the extent possible, for example. And also we had to look at the risk factors of different pathologies so as to provide different levels of service. All of that helped our care model significantly. Now, some numbers. We always try to make certain that the services responding to the model, more than 65% of all the services provided care during the entire pandemic. So the service did not stop, but a lot of the care was in person only if necessary. And in more than 90% of the cases, the care was maintained thanks to being able to use telemedicine as a strong support. Other things that changed was we have had to reduce the frequency of seeing people, especially when they would come in to pick up medication. That visit, we tried to deliver medication for 3 months so as to have a visit that we could make good use of in terms of comprehensive care. Now, in terms of mental health, here too, mental health had been set aside to a certain extent within public health, and it is a major challenge in the pandemic. So much so that the pandemic has actually been a catalyst in terms of plans for mental health plans. Because of this, the team has had to work on a national plan, and also the pandemic has strengthened this area of practice. Now, we had major communication campaigns regarding mental health. We strengthened our team working on information technology. Telemedicine was also very helpful, and here we worked with the people from the Pan American Health Organization. So all of the professionals working in their mental health have delivered services at a historic level. And we have worked with universities, with other partners, other stakeholders. Now, this shows you an illustration from our mental health campaign. Notice that the mental health approach shares the approach of chronic disease in terms of a healthy lifestyle, physical activity. All of that is part of our model for chronic care. And now in concluding, I wanted to show you something quite interesting about mental health. And the important thing about mental health online, this is what we call the detox for mental health in the time of COVID. So we need to disconnect. We know that in addition to the pandemic, there's also perhaps an overwhelming amount of information, and often it's misinformation. So we think it's very important to work on mental health by talking about life online. So this is an interesting experience we have been engaged in with other entities. So now we can go to I think that was my last slide. Okay, so this is the experience we have had in Paraguay, and I look forward to hearing from you so we can discuss other experiences we have had. Thank you.
Great. Thank you very much, Dr. Guillermo Ceguera, for sharing with us these very insightful lessons on how the Paraguayan government has been implementing the chronic care model and the adaptations that you've made, like telemedicine and the focus on mental health to ensure people receive the care that they need during this pandemic. We move now to Jamaica to learn about how the impact of COVID-19 has been managed in the country and the government's response to ensuring health services for people living with NCDs. And speaking with us today is the Honorable Christopher Tufton, Minister of Health and Wellness of Jamaica. Dr. Tufton has a doctorate in business administration, and in addition to serving as Minister of Health since 2016, he's also a member of Parliament for West Central St. Catherine. He also has served in the past as Minister of Industry, Investment and Commerce, as well as Minister of Agriculture and Fisheries. And in fact, for his impact on the agriculture sector, Dr. Tufton was named by the very influential Jamaica Gleaner as Man of the Year for 2010. It's an honor and a privilege to have you with us here today, Dr. Honorable Christopher Tufton, and over to you.
Thank you very much. Madam, is it up? Yes. Okay. So today I will, first of all, let me thank you for the invite, and to those who are participating. Thank you for listening. I'm going to share with you the strategic goals and objectives that our ministry has put out that would seek to address some of the main challenges, COVID being a key one, and explore at the same time components of our health systems from leadership and governance to service delivery. And finally, to look at the way forward and how that projection will make us stronger and more resilient for the future. The first slide here is part of our own strategic outlook and some targets that we have set for ourselves, guided, of course, by the WHO and other critical benchmark practices, health system practices.
Morning, Minister Tufton. We seem to have a problem with your volume, with the sound.
Oh, you're not hearing?
You may be muted.
Are you here? Is it better now?
We can hear you, Minister.
Okay, great. All right. So I have placed on the screen the first two slides dealing with our strategic objectives, which are guided, of course, by the best practices in coming out of various expert groups, including the World Health Organization. And beyond that, we have divided, next slide, into our approach into critical areas of overall service delivery, looking at leadership and governance, or human resources, medicines and technologies, financing, and information. And I'm going to take us through each of those very quickly and contextualize the issues around COVID. In the first instance, you will know that NCDs have been brought to the fore because of COVID, because most of our most significant impact certainly the casualties, the deaths, are linked to persons who have comorbidities, persons over 60, persons with one or more NCDs. And that is the experience of Jamaica, where over 74% of our deaths were linked in that category. And as you know, it is also the experience globally, which tells us that the real challenge of the epidemic of NCDs and why it's important to combat this through our various strategies, health system strategies, in order for us to be more resilient going forward to the future, not just to overcome COVID, but other ailments. So leadership and governance for us around NCDs. The National Committee was established with a multi-sectoral advisory group, and that's because we feel that we have to have an all-of-society approach, and the multi-sectoral advisory group pulls on all sectors, government and non-governmental, as part of the conversation that is necessary so we can adopt a holistic approach to NCDs. That National Policy for Model of Care, the chronic care model for NCDs, was developed back in 2020 and is now being modeled for implementation. The evaluation of our current and development of a new national strategic plan for NCDs, taking us to 2030. And in the context of COVID, a lot has been learned, and the importance of this plan has been re-emphasized through very practical experience that we have had. And then we are developing the primary healthcare renewal policy, which gives a focus on how to improve the healthcare systems delivery at the community level. One of the very big advantages we had with the COVID response is the fact that we have over 325 primary healthcare institutions across the country, with the guiding principle being no one should be located beyond 10 miles of a primary healthcare institution. And we had a significant number of primary healthcare support to support our primary healthcare clinicians, and moving into the communities to provide information, to do contact tracing, was a very key part of trying to control the spread of the virus. Next slide. Beyond that, the root causes of NCDs, we are attempting to address through tobacco control legislation, now before a joint select committee of parliament, alcohol policy or alcohol abuse policy, which is about to go to cabinet, and a national food industry task force, where we have established interim guidelines around beverages in schools, national school nutrition standards, and production reformulation workshops, particularly in the first instance, targeting sugar reduction in our beverages. These are all initiatives that are geared towards addressing the root causes of NCDs in our population as part of an overall strategy of changing lifestyle. Beyond that, in terms of service delivery, we have looked on the mental health, and mental health has been a big issue within the COVID experience. The restrictions have come with anxiety, with depression, and we went out and pivoted around addressing those issues by establishing specific programs and beefing up others to deal with mental health. So we engage in significant training, working with the Jamaica Red Cross, Jamaica Psychiatric Association. We establish greater communication access for help through a 24-hour helpline. And we provided additional critical capacity in different parts of the country for outreach. These are things we're looking at now to standardize as part of our way going forward, which would have come out of the COVID experience. Next. The other area is service delivery, and we created a concept some years ago around physical activity, nutrition, and knowing your health status, and we call it Jamaica Moves. It has since gotten support from various institutions. The WHO, we did an execution at the UN high-level meeting. CARICOM, we now have a CARICOM Moves, St. Kitts and Nevis Moves, Barbados Moves. So it has been patterned by others in the region. And the fundamental principle of the Jamaica Moves program is to influence behavioral change by tapping into culture, into the music, into the lifestyle, to make physical activity fun rather than just prescribing what is clinically correct. So we try to engage the population and to engage them in a way that will boost behavioral change. That was very important for us in terms of COVID. While we could not go out in the field to host events, we used mainstream media with a television program twice a day for students who are at home, but also for adults, so they could work out watching the television executions as you see on the screen now. And that worked, plus other forms of important initiatives that we created, including pop-ups, limited numbers nevertheless, but to create awareness, social media. And in addition to that, we have promoted the nutrition aspect by providing a symbol in restaurants using policy and moral suasion to identify more nutritious options within those restaurants. And we call that the Better For You menu. And that has been rolled out among a number of quick service restaurants, having hundreds of locations across the country, and so far is going well. And we feel that's a start of nudging consumers towards healthier options. Next slide. The school program was also launched, where we got our students to be more active by developing specific programs, but also through the nutrition element. As said earlier, we have established minimum standards and a reduction of sugary drink content in schools as a critical part of driving healthier behavior within our younger population. Next. And at the workplace, there was a similar program that was set up to encourage workplace activities, so that we promoted, again, the same lifestyle changes at work, at school, and at home as part of the overall nudging for healthier behavior, which of course builds the resilience against the NCD epidemic that we face. Next. Service delivery, we try to partner with the private sector on a number of initiatives, one involving diabetes and hypertension. So instead of overcrowded public hospitals, we sought to engage some private practitioners and essentially arranged an agreement with them so that a number of patients, clients who would normally go to the public institutions would now be seen by private practitioners based on that agreement. And that sought to discourage the overcrowding in some of our public health institutions and created a partnership which we believe is good for the overall messaging of coordinating a national response to the NCD challenge, in this case, diabetes and hypertension. Beyond that, we have done work in sickle cells by providing greater access to drugs, and also where there have been shortages in diagnostic and radiology services, we have also signed an agreement with private sector providers to provide these diagnostic and radiology services, which again cut down on waiting time and allowed us to treat with these patients or clients a lot quicker. We have also established the food-based dietary guidelines, screening guidelines for NCDs, and interim guidelines around diabetes and hypertension, and protocols around nutrition, all geared towards creating a regulatory framework that will bolster best practices and standards in light of the challenges that we face. We're also, and very timely, moving towards significant infrastructure development through an arrangement with the Inter-American Development Bank, a number of hospitals and health centers. We have gone well advanced in the designs of these institutions. Many of them are upgrades, not totally new, but nevertheless, we have taken into account the need to be flexible, to be resilient in our institutions, to deal with emergencies like COVID, and to allow us to have a stronger response. And that is now being done as we speak, which involves things like telemedicine, tele-echo, training, and of course, the wellness component, which I mentioned earlier. Next. Information is absolutely key to this process. So we have spent some time looking at labeling arrangements to create greater consumer information, which we think is a right. The right to health should involve the right to information. And so we are now addressing that, looking at front of package labeling. There's a lot of pushback from industry. And so it's a battle, it's a process, but it is our intention as government to continue this thrust. In addition to that, we're partnering with our educational institutions, and we have conducted baseline studies in this instance on trans fats, where some 40% of our common foods consumed have some element of trans fats. Of course, Jamaica is committed to the elimination of trans fats, so it at least creates the baseline study for the work that has to be done going forward, which we feel is necessary. Electronic health records are also being developed through the IDB program, and that will be rolled out in a few months, all about information, capturing information, processing information, and therefore allowing us a speedier response. In terms of medicines and technologies, we're also working to improve our capacity to equip our institutions. And this again is through the IDB program. And the use of the trans fat study, as said earlier, we are, I think, the only country now in the Caribbean to have captured that base data. And that data is going to be used in a major way forward in terms of how we treat with the information, but also the challenges that we face with the consumption patterns that are unhealthy. Next. Financing and human resources are also a critical part of our way forward. COVID has caused us to increase our health cadre of our staff by some 18% over the last year. We hired additional community health aides to do community outreach. We created more positions for nurses. We hired additional doctors. And so in a sense, we have upsized our capacities to respond at different levels of our health institutions and are now reconfiguring our organizational chart to capture and maintain this new cadre of staff and to train in areas that makes them more relevant to the challenges that we face across the board. Included in that is also in the behavioral sciences through health promotion activities. Because while the clinical sciences are important, as we all know, we think a big part of the NCD challenge is to get human behavior response. And so the social sciences as a critical part of the clinical prescription is also very important. And we're placing some emphasis there. Next. On the horizon, where do we go from here? Jamaica Moves brand will be expanded around behavioral change, again, tapping into culture at the workplace, at home, and in schools. The issues around labeling will continue to be a big discussion point, captured around the theme of consumer right to know what's in their foods. We will use both mainstream, traditional, and non-traditional media to push these messages as we feel it's important. Comprehensive tobacco legislation will come, as well as harmful use of alcohol policy, and hopefully therefore curtail the temptation for indulging, or in the case of alcohol, for overindulging. And we will support that with information. The salt and sodium or sodium study, marketing of foods to children. We have established a research fund around wellness to tackle some of the main challenges we have, and the physical activity program, which we will assess as we go along, including the Jamaica Health and Lifestyle Survey, which is done to capture information on the state of NCDs. These are all programs that are ongoing, and we will seek to bolster recognizing our threat coming out of the COVID experience, but also a recognition of the NCD pandemic that we face, or epidemic that we face. And that's it for me. Thank you very much for listening.
Thank you very, very much, Minister Tufton, for this extensive and excellent presentation on your leadership to strengthen the governance and the health systems and services in Jamaica to improve care for people with NCDs. I particularly like the governance issues around setting up the chronic care policy, the multi-sector commission, focusing on primary healthcare renewal and community supports, as well as the Jamaica Moves and Wellness campaign. So congratulations again to you, Minister Tufton and the team. We turn our attention now to our partner organization, the Inter-American Development Bank, the IDB, on how they're working with countries in the Americas to strengthen health services during this pandemic time. And we have with us today our dear colleague, Dr. Ferdinando Regalia, who's an economist and division chief of the IDB Social Protection and Health Division, and who's leading the IDB support to its borrowing member countries on the response to COVID in areas of health and social protection. He oversees a large portfolio of technical assistance projects and lending operations throughout Latin America and the Caribbean, and has led the design and implementation of innovative public-private partnerships and results-based financing platforms. So he's going to speak to us today about IDB's work on health system strengthening for NCDs. Ferdinando, over to you.
Thanks very much. I will make my remarks in English. Good morning to everyone. I hope you are all well in these challenging times, and it's a real honor to share the virtual floor with Dr. Vice Minister, Dr. Sosa, Director, Dr. Sequeira, and with Honorable Minister Tufton. I want to begin by thanking the Pan American Health Organization for bringing renewed focus to this topic and for inviting me to participate. We are keenly aware that even under the stress of struggling with COVID-19, PAHO is keeping attention on the bigger picture of health in our region, and NCD risk factor and mental health are a large part of that picture. I would also like to thank PAHO for its technical leadership through the crisis and the spirit of collaboration with which our two organizations have been addressing a wide variety of issues, from governance of digital health, issues of vaccine procurement, evidence on effectiveness of tobacco taxes, and fight to malaria. The next, please. Next slide, please. In April, the IDB approved an updated of its health sector framework. It's a process that we conduct every 4 years. Despite the obvious pressure of the pandemic and necessary attention to public health function and emergency preparedness, the updated framework that we develop gives more explicit and heightened attention to NCD, their risk factor, and mental health. If there is one message that comes through the updated framework, is that unless we seriously address primary prevention and quality of care, we will not be able to afford the cost of treating the diseases in the future. It is within this context that I offer these thoughts. First, I will discuss what we have learned from the pandemic, and then I will try to characterize some lines of action that we hope can get us beyond some of the difficulties with healthcare services and health promotion that we have faced in the past. The next slide, please. The first things that we saw with the pandemic were and we still are seeing, is that the enormous effort to hold the transmission and to treat the surge of patients with life-threatening COVID condition. But soon became clear that population health was also threatened by disruption in non-COVID healthcare services. A growing body of empirical evidence is emerging. Dr. Ennis already presented a survey that found that 20 countries in the region report partial or complete interruption of non-COVID healthcare services because of declining routine vaccination. Other studies, also some of them sponsored, have documented neglect of non-COVID condition at facility or population level. For example, people have postponed routine examination for diabetes and hypertension, interrupt treatment for chemotherapy, and even in some cases, forgone seeking emergency treatment. This level of disruption shows the difficulties of addressing health systematically, of maintaining high-value services in the face of new pressure from the pandemic. The next slide, please. So what are we learning from the pandemic? In some ways, it has emphatically reaffirmed many familiar challenges. Watching healthcare services struggle with the influx of COVID patients has highlighted the difficulties many systems face in providing good quality care, whether due to inadequate infrastructure, staffing, training, or procurement capacity, or due to weaknesses in information, coordination, and management. It has also demonstrated the challenge that face systems where we lack an appropriate balance between curative care on the one end and prevention and management of diseases on the other, and between adhering to procedure and making the innovation and adjustment we have just seen in the two presentations to assure good health outcomes. Further, the pandemic has highlighted the terrible toll of NCD because of comorbidities that contribute to the population vulnerability to the virus, and because social distancing policies, which are necessary to slow transmission, have exacerbated a range of mental health conditions. In a situation with sharp fiscal constraints and large healthcare demands, the pandemic has also shown the difficulties of obtaining and managing resources to improve healthcare service performance. The next, please. The pandemic has also highlighted vulnerability with which we are less familiar. Public health function meant to detect, respond, and control infectious diseases faced enormous pressure, and many were unable to fully fulfill their roles. The inequity in access to good quality health care in the region are long-standing, but the pandemic has sharply exposed those inequities. For example, poorer households are likely to face harsher economic consequences if they comply with social distancing policies, and are less likely to get necessary care if they are attended by provider organizations with fewer resources than other segments of the healthcare system. Public administration is another area that the pandemic has put in the spotlight. The emergency has exposed tension, for example, in fiduciary control procedure, which try to assure integrity without hindering efficient performance. And when they fail, we call them red tape. When they succeed, we call them good governance. We have also seen the compartments between diseases groups breaking down. While classification is useful, compartmentalizing policy can become a problem when we ignore the relationship between NCDs and infectious diseases. The current situation has been called a syndemic because of the combined effect of NCD and COVID in contributing to severe condition and death. Finally, the pandemic has shown that where data and information are lacking, preventing and managing disease is extremely difficult. Right now, countries around the world are willing to spend considerable amount of money for extensive COVID testing to decide whether people can attend university or social events. Nothing wrong in it. But many countries don't spend enough resources to find out who is in the early stages of diabetes or vulnerable to cardiovascular disease. The pandemic has shown the value of epidemiological surveillance for infectious diseases, but for those who are really paying attention, it shows the value of data systems to help screen, monitor, and manage NCD tools. The next slide, please. The pandemic is a huge tragedy, but when society responds to the tragedy, they often find unexpected strength. And the cases that have just been presented before from Paraguay and Jamaica show it. This has been true with COVID-19 too. We have seen many cases where governments have enacted new laws or modified health regulation in record time. These have facilitated procurement of supply, reassignment of staff, negotiation of vaccine, and innovation in treatment. Countries have moved particularly quickly, and the previous panelists have highlighted it, in the digital transformation of health. Remote consultation have increased by a factor of more than 100 in many countries for which we have data. Some countries have temporary ease requirement for remote consultation or electronic prescription. Many of these changes are either permanent or are likely to become permanent. Use of digital transformation among health providers or to improve communication between providers and patients, phone application for screening and education have all been boosted during this period. Management and cross-sector coordination have also undergone changes. For example, from our vantage point, we have seen an increase in strengthening the linkages between primary care facility and hospital to coordinate screening, treatment, and admittance. Developing more ICU databases and improving utilization through coordination across facility. Developing communication strategy and engaging in new ways with communities to promote public health messages. If countries can build on this ferment of activity, it may be possible to move the health sector forward and get beyond the challenges of the past. The next slide, please. What would that look like? In many ways, the line of action for the future that we reflected in our new IDB strategic framework for health sound like the same unfinished line of action of the past. Promote integrated network, improve resource allocation, improve quality, reduce inequities. But they are not the same when we look at them with the sense of urgency generated by the pandemic. Health is a systemic outcome, making primary prevention an essential feature of public policies, as shown by the previous speaker. Without tackling major risk factors contributing to the burden of NCD, such as tobacco and alcohol consumption, diet and pollution, no country will be able to afford to treat the diseases that will face us in the future. We can also see that quality improvement is not an add-on on healthcare access. To the contrary, focusing on improving healthcare service quality could be the way both to expand access and to drive the integrated people-centered care that will make services more effective and more efficient. Strategy to digitize health record, collect better data, and use the information for managing diseases are not a novelty anymore. The changes needed to implement digital health could provide a focused plan around which country can transform the model of care and ensure the kinds of secondary prevention needed for managing NCDs. And finally, the big issue of resource mobilization for health, which is going to be a continuing struggle in countries where fiscal constraints have gotten much tighter than before. This might be more manageable if the debates over resources become more fully engaged with the discussion of how money is spent, how it is allocated, the quality of the services it buys, who gets the services, and what results it can achieve. So, to conclude, health promotion, health service quality, digital transformation, and improvement in the use of resources do not sound like new lines of action. However, this pandemic has shown that they can be pursued with greater vigor in ways that could really make a difference to the burden of NCD and mental health today and into the future. Thanks very much, and I return the word to Dr. Silvani. Thank you.
Thank you very much, Dr. Regalia, for your continuous dedication and collaboration to support health system strengthening and social protection, especially for digital health and financing for health, which are most needed at this difficult time, and particularly for NCDs. So this webinar has focused on transforming health systems for optimal NCD management. And we've heard about PAHO's work on NCD management. We just heard about IDB's work in this area. And we also heard about experiences from two countries, from Paraguay and Jamaica. So we now conclude with a final commentary from PAHO's Health Systems and Services Department, from the director, Dr. James Fitzgerald, who's leading the organization's work on universal health coverage and access, and working closely with member states to improve health systems and services. So I pass the word over to you, James.
Thanks very much. Thanks very much, Savannah. Very good morning to you all.
You're on mute, James.
Oh,
never mind. Yeah, all good.
Okay, so very good. Good morning, Savannah. Thank you. And also my thanks and recognition to Minister Tufton for the excellent presentation. Also to the Vice Minister of Paraguay, and of course our colleague and friend Ferdinando from the IDB. I wanted to focus the few minutes I have this morning for you, building on some of the presentations and what we've heard from the presenters in this panel, and to begin to look forward, based on the lessons learned of the pandemic, to what we can see or what we hope to see in terms of the development of more greater resiliency and capacity within our health systems, not just to be better prepared within the context of a future emergency, but to better respond to the needs in health of all populations in the Americas. We are moving forward with the development of a proposal which the Ministers of Health will be taking up, first of all, in the Executive Committee of PAHO on building resilience in health systems, and thereafter in the PAHO Directing Council this year. And it really focuses on taking strategic and targeted actions to address the long-term systemic deficiencies so well highlighted by Ferdinando, but also the structural elements that have been exposed by the pandemic to build resiliency in health systems, rapidly expanding access and coverage in health, addressing those health inequities, but also environmental risk factors, and also consolidating on some of the innovations we have seen that health systems have adopted during the pandemic response. We're looking at 4 key areas of work in this proposal to guide member states, of course, applicable to the national context and structures and organizations of health systems. But central to each of them is really the strength in leadership, stewardship, and governance for health systems transformation for the future. The first area of work that we're really looking at is to accelerate our agenda in the transformation of health systems based on the primary healthcare strategy. We do believe that this can accelerate pandemic recovery, recuperate public health gains and sustain them, and allow us to retake the path towards the achievement of the Sustainable Development Goals. Primary healthcare, as you know, is an approach that addresses the needs of people, families, and communities where they live through the organization of comprehensive, integrated, and quality healthcare services within the communities. And it really builds on the continuum of care, from health promotion to disease prevention and control through diagnosis, treatment, and palliation, if so required. We're calling on member states in our governing bodies this year to really renew their commitment to the recommendations of the high-level commission that was led by President Bachelet in 2019, and the call made by Dr. Etienne in Mexico in April 2019 around the Compact for Primary Health Care. This compact calls on member states to transform their health systems based on the primary health care by eliminating barriers to access care in the order of 30%, increasing public financing to at least 6% of GDP, and allocating at least 30% of these resources to the first level of care. If we look at the analysis of health financing across the region, we see that as of to date, and noting the wide variation across countries, only 24% of public expenditure is allocated to this important level of care that can respond, in essence, to 65–70% of health needs, according to WHO. The second line of action really speaks to the key issue of leadership and stewardship and governance, but not just simply across in the transformation of health systems, but really building on something that we need to retake with vigor, which is the essential public health functions. A whole of government and whole of society approach is needed to enhance our public health capacities and to design and strengthen the institutional structures that can facilitate the coordination between public health interventions and programs across the sectors. We have taken steps to strengthen the capacities for the performance of the essential public health functions. We've launched a new framework in December 2020. The framework calls for actions broadly in 4 areas in terms of evaluation of the health status of the population, recognizing the differentiated needs of those population groups, formulating and implementation evidence-based policies for health promotion and protection, both at the national and subnational levels, Ensuring the allocation of resources thereafter based on the policy definition to address public health capacities, and then ensuring access, universal and equitable access to all public health interventions. And these are irrespective of whether they're individual health services, community health services, or population-based health services. Our third line of action really speaks to the issue of the capacity of health service delivery networks, the capacity to expand access, and also to improve preparedness in response to public health emergencies. An integrated, well-resourced and managed health service delivery network is fundamental to ensure universal and equitable access to all public health interventions, but also to individual and community health services. There is a need for us to develop the capacities in terms of adaptability and response and reorganization of the health services network. And this is something we've seen very clearly coming out of the pandemic, including healthcare surge capacity. Critical to this is the capacity of the first level of care. And we believe that in terms of NCD control and management, strengthening the first level of care through the organization of interprofessional teams of care, working with community health workers, adopting some of the innovations we've seen in digital health during the pandemic, we can really increase the capacity of health systems to outreach into communities and to begin to address the enormous burden of NCDs throughout the region. A strong first level of care can also assist in the rapid recuperation of lost public health gains, while constituting also a fundamental investment in the future health of people and communities, and also in the resilience of future health systems. The last line of action is so critical. It really relates to public financing, not just in health, but also in social protection, including for actions to address the social, environmental, and economic determinants of health. We are very aware of the precarious economic outlook for the region of the Americas, and within this context, it will be a challenge for countries to sustain and increase public financing in health. And so we will continue to work with countries to adopt the necessary mechanisms and processes to continue to allocate sufficient resources, public resources in health, while ensuring the necessary efficiencies that are so needed. Aligned with this will be a call to increase investments to develop capacities in the essential public health functions, but also in those functions related to IHR compliance and disaster risk reduction and management. Investments in the first level of care have to be prioritized. Coming back to the Primary Healthcare Compact, where we allocate at least 30% of the total public health expenditure to the first level. And we need to continue to work with countries to examine within this precarious economic outlook the necessary fiscal space and pooling, the capacities of planning and financial management for health systems to improve efficiency and to reduce the segmentation of financing. Finally, intersectoral action, I think we've heard across all presentations, intersectoral action is going to be key to support health, social and public financing functions and to address the broader social, economic, social, environmental and economic determinants of health. I will leave it there. Thanks very much, Savannah, and congratulations to all participating in this event.
Wonderful. Thank you very much, Dr. Fitzgerald, for these reflections and emphasizing the importance of governance of a health system, the essential public health functions, and a focus on first level of care, especially to improve outcomes for people living with NCDs. So this concludes the formal part of the presentations of our webinar, and we really hope that you've gained a deeper understanding and appreciation for the impact that COVID-19 has had on people living with NCDs and what can be done from a health system strengthening perspective to improve NCD services, as well as some examples from the region on what is currently going on. And I'm certain that a lot of these presentations has sparked among you, our audience, our listeners, some questions and comments. So I invite you, if you haven't already done so, to place your questions in the Q&A box in the Zoom platform. You can find that at the bottom of the Zoom screen where it says Q&A, and simply type your questions in English or Spanish. And we'd like to start a conversation with you now to hear a little bit more from your perspective, from your experience, from where you're sitting. How can health systems and services be improved to strengthen services for people living with NCDs and ensure continuity of care, especially during this COVID-19 pandemic. So I invite you again, please write your comments or questions in the Zoom, and I will be managing those and directing the questions appropriately. And so while we're waiting for people to add their questions and comments, some people already have, which is really nice. Thank you. They've already jumped the gun. So one of the comments that has been made and questions from Karen Kinder is around investments in health. We've heard that in perhaps each of the presentations, and we know that one of the building blocks of health system strengthening is around financing the health systems and services. And so the question that Karen asks is, investment in what? Is it better to invest in public health functions or better to invest in primary care, or what specifically to improve, especially NCD care? So that's a question that I'd like to pose to all panel members, because I think we all bring our perspective and our views. And I'd like to start perhaps with Dr. Hennis to reflect a little bit on investment.
Yes, fine. Thank you so much, Silvana. Now, I think everyone gets worried about what does investment mean. We have very clear perspectives that we should invest 6% of public funding to the health sector. And then again, after that, what happens next? And I think James Fitzgerald just gave us a very clear idea that 30% of the investment should go to the first level of care. What does investment mean? It means financial, it means currency, hard cash, and then the distribution of hard cash depending in terms of what the actual health needs are, what are the priorities of the health system, and then again in terms of investment in terms of training, investment in terms of infrastructure. We heard some very clear perspectives from Dr. Tufton, the Honourable Minister from Jamaica, about investing in infrastructure and hospitals and clinics, etc. So there are very many different investment needs. So it's not a question that one can simply say simply, if you get this amount of money, you need to get this amount of money, you need to put it here or there. That is going to be a very specific issue depending on what the country priorities are, what the country needs are. And even in terms of investment, it's also the context of investment in terms of regulatory frameworks. And it was very refreshing to hear that stated again about looking at the causes, the underpinning causes of NCDs. So you may invest a lot into a health system to provide care, but if your patients then leave the clinic and go and smoke and eat junk food and drink sugar-sweetened beverages and alcohol, that investment is wasted. So it's going to take a whole of society, whole of government approach, and a significant degree of governance in terms of making sure that all the systems interdigitate to provide the response that you need. So I've said a lot, but really the bottom line is there's no one-size-fits-all formula for the investment. That's going to be very, very specific depending on what the priorities are, depending on what the needs are, depending on the populations that you're serving. Hope that is helpful.
Thank you. Thank you very much, Dr. Hennis. I'd like to hear now reflections from the Minister of Health of Jamaica on the investments. I know you have extensive experience and debate in the country on this question. Over to you, Minister Tufton.
Minister Tufton had an emergency, so he had to run. We're very sorry.
That's okay. Thank you for letting us know. Thank you.
Yes, we'd sent a message internally. All right, thank you.
Apologies, I didn't receive. Thank you, and all our congratulations again, and thanks to Minister Tufton for his participation in our webinar. So we'll move to Paraguay, to Dr. Guillermo Ceguera for some reflections on investments.
Sí, en nuestro país, para el proceso.
Here in Paraguay, in terms of chronic disease, this is something we've been working on since 2013, 2014. And in our planning, we included control of chronic disease, but the pandemic represented a shock for us. And it caused us to stand on standby for a couple of months. But I think that the pandemic has really led us to focus on chronic disease, not only in terms of care or infrastructure or greater care, but in terms of our objectives too. We're looking at lifestyle. We have very interesting indicators where a lot of people have stopped smoking, for example. There are indicators from last year and this year, and we see that smokers have either stopped smoking or are smoking less. Also, regarding physical activity, we have some interesting indicators showing that physical activity last year didn't change all that much, but this year, people are taking physical activity very seriously. They see it as a way of living a more healthy lifestyle. Now, we have shared preliminary reports on improved lifestyle for a large part of the population, and that is essential. It goes beyond just paying for more infrastructure or having very good care protocols. We keep those up to date. But it's important that our people understand that the battle against chronic disease is a battle that is waged by the community, and it's closely related to lifestyle. Otherwise, the need for investment would know no limits. So it's very interesting.
And the IDB, over to you, Dr. Regalia, for some reflections on investment in primary care versus public health and what some of the options are.
Perdón, que no sé si me escuchan, sí.
I hope you can hear me. As Dr. Hennis was saying, this is country specific. I think that the most important thing is the role that organizations like ours can play. We have to support a good decision-making process. In Central America, we're having a great experience. Right in the midst of the pandemic, countries like Honduras are thinking about where they should invest their resources so as to comply with the goals presented by Dr. Hennis at the beginning of the seminar. What investments are most cost-effective? Now, here it's not like we are reinventing the wheel. So there is a need to invest in an essential public function, and also we need to strengthen primary health care so as to deal with chronic diseases and other diseases too. So moving that discussion away from something just discussed by the health ministries to include the finance ministry too, that is a way to see where we should invest most cost effectively. And that has to be done systematically, and it's country dependent. And almost it is state or province level decisions that have to be made. Thank you.
Excellent points, Dr. Regalia. Thank you very much. And in the area of NCDs, we have a set of cost-effective interventions. And of course, it's a very long list of interventions because NCDs are very broad, but it is a good starting point. So last word over to you, Dr. Fitzgerald, for some reflections and comments. I know you have extensive experience and processes in guiding countries on investments. Over to you for comment on that question.
Yeah, thanks, Silvana. Yeah, just to complement what the previous panelists have indicated, I think our investments should be targeted based on what we are trying to achieve, and that is to really move forward, recuperate the lost public health gains. We've seen countries suffer almost 14 years of loss in terms of poverty alleviation in the region. I'm sure the data that we've seen in this panel has indicated the impact in terms of essential health services and what will occur down the line in terms of excess mortality and morbidity for NCDs. So our financing really needs to begin to look in the short, medium, and long term about how we recuperate those losses, address the persistent and growing inequities that are observed within the countries. And there is always this struggle within health systems where I suppose the higher levels of the health services are demanding more and more resources as technology, the level of technology incorporation becomes more intense. And so the hospital-centric models of care will require additional resources, but they're not going to resolve to the level of satisfaction that we require the health needs of the population. If we don't address what Ferdinando was talking about, even in terms of the primary prevention or even secondary prevention of NCDs, by investing in the health at the community level, addressing the differentiated needs of populations in NCDs and beyond, while then we will continue to see the upper levels of health systems demanding more and more resources to address those situations where care has been delayed. And so this is a very important discussion, I think, that we need to have with countries to show them that now is the time to do it as a cost-effective measure for the future, not just in terms of the health and well-being of the population.
Yeah, excellent, excellent. Thank you very much, Dr. Fitzgerald. And so we'll conclude with one last question, which I think has been highlighted in several of the presentations. And this comes from Mark Barone, a strong collaborator of ours and participant in some of our work on NCDs. And he asks, what would the panelists recommend on engaging private sector in partnerships with the public sector and civil society to overcome the challenges that we're facing now, that is to improve NCD services during the time of COVID? And linked to that, Mark also asks, what is the formal processes of engaging with people living with NCDs in these decision-making processes for health programs and health system strengthening for NCDs? I know very complex questions, but I'd like to conclude with just some reflections from each of the panelists on this point. And let's start with Dr. Regalia from the IDB.
So very, very, very briefly, I think this is a very important issue and difficult to discuss in 15 seconds. But I would like to highlight, for example, Honorable Minister Tufton is not here any longer. But we actually had a great experience of supporting, for people who are not technical in bank language, it's a budget support. So it's a fiscal support to the country, but rooted in discussion of new legislation and primary healthcare intervention that needed to be passed by Jamaica. And that process was, of course, led by the country, very inclusive, including patient groups and private sectors, as we have also heard from the ministry. That is the ideal situation in which even institutions like ours can deploy financing mechanisms that really are budget support mechanisms that are linked to processes that are very encompassing of all the stakeholders involved in this discussion.
Yeah, okay, thank you. Thank you very much. Excellent. We'll pass now to Dr. Guillermo Seguera, if you can reflect on engaging with private sector and involving people living with NCDs.
Sí.
Yes. Well, with the private sector, we still have an enormous gap with the non-communicable diseases from public health, from the public sector, and the articulation with the private sector. There's an enormous gap, mainly in the urban centers. Now, as to the peri-urban and rural sectors, since there's practically main access to the public sector, the response is more from the public sector there. But it's true that it's a pending debt, this coordination of care of chronic diseases and mental health as well. The harmonization with the private sector, there are partnerships, there are many projects on paper, there are discussion tables, there are interdisciplinary groups where at least we've tried to come to a consensus on protocols and management guides and things like that. But the private sector, the way we'd like to work with the chronic model of care, the private sector is not really offering that side of community work that we want to implement, because we cannot imagine care only for chronic diseases in general without the work and the empowerment of the community. Not just the individual himself, but a community, an organized community. That is a challenge for our country. And that's about what I can say. Thank you very much, Dr. Seguera.
We move now to Dr. James Fitzgerald for some reflections.
Yeah, thanks, Savannah. This is a really complex question, but if we look to see what's actually happened during the pandemic, we see that a number of countries have really successfully mobilized the participation of the private sector in the collective response. And this, I think, is the way it should be. You know, when we talk about a health system, it includes all the entities and organizations responsible for the health and well-being of the population, and the private sector has a fundamental role there to play. The question really arises in terms of the governance and regulatory mechanisms that we need to put in place to ensure that we address the equity considerations in terms of allocation of resources and the organization of health services. It's a very important discussion, but you know, the private sector is growing in the region everywhere, and this is something that I think we can really mobilize and bring to bear their capacity to also improve NCDs and mental health throughout the region.
Excellent. Thank you. Thank you very much. And now for final comments, and to also conclude, I'll turn the word over to Dr. Anselm Hennis as we've come now to the conclusion of our webinar. So Dr. Hennis, over to you for some reflections on the questions and concluding remarks for the webinar. Thank you.
Thank you so much, Silvana. And I think it's important. I think private sector engagement is very, very important, but I think one also has to be mindful that the private sector is not homogenous. There are areas of the private sector where they can work as ethical collaborators and they work in the interests of the well-being of countries and the populations. And there are also sectors of the private sector that actually work against health. These include areas such as firearms, tobacco, and you might have issues of areas, for example, marketing and distribution and production of, for example, harmful foods and alcohol. But that's a more complex discussion. But I think in the end, you can certainly work with the private sector that's working to engage in promoting health and well-being. I think you do it without any problems. And I think really one has to find ways to build a whole of society engagement. And we keep saying that. But I think, as James said already, the whole issue in terms of governance is going to be very, very important. As an agency, we're bound by rules in terms of safeguarding against conflicts of interest. So we have this FENSA, framework of engagement with non-state actors, and that is also relevant to our engagement at country level. And I think quite often too, there are mixed messages when governments and ministries, on the one hand, take a position, but do something which is totally at odds with the position in terms of the interests of health. But I think with the safeguards in place, etc., I think this is an important area to consider in terms of recovering from the pandemic. And very definitely, one needs to have persons with non-communicable diseases at the table and in the discussion-making process. So on that note, I really wish to thank all of our presenters, representatives, the ministry, representatives from the Ministry of Health of Jamaica, the Honorable Dr. Tufton, also the representatives from the Ministry of Health of Paraguay, Dr. Seguera, I think, and Dr. Sosa, I believe. Also, we'd like to thank our friend and long-standing colleague, Dr. Ferdinando Regalia. I'd also like to thank Dr. James Fitzgerald. Also, I'd like to acknowledge the support and help from Dr. Barbosa, who gave the welcome remarks. And of course, I'd like to thank Silvana for moderating it and the team that was supporting the effort to bring this all together. And of course, I'd like to thank each and every one of you, the participants, who without your help, this would not have been possible. And I think this has opened a space for further engagement about how we strengthen our health systems in the recovery phase post the pandemic and during the latter stages of the pandemic, we hope. So again, thank you very much. Indeed, a pleasure to have you all. I look forward to continue the discussions. Thanks again, and goodbye from all of us. Thank you.
Thank you. Bye-bye. Thanks.